on stage. And just to clarify, what you said at the end, Vijay, you were talking about lungs that will be manufactured on an armature that is 3D printed and then essentially grown through your combination with, what's the company called again?
United Therapeutics.
United Therapeutics, okay. Well, thank you so much for that. Now, let me just, Roy, how are you?
Good, how are you?
So good that you got here.
Yeah, 5 minutes.
Roy cut it a little close, but he made it. We're wonderful. We're happy about that. So I'll start with introducing, Roy is Chief Medical Officer for the Global Connected Care and Healthcare Informatics Group at Philips. He's a doctor who has only joined industry in the last couple of years after a career running hospitals and doing an awful lot of innovative things in the healthcare industry, so to speak, about which he has impressively strong opinions, which I hope will be displayed on this panel. You've met Vijay, who I introduced before, really one of the great business leaders in American business, who has turned to his new job, turning around 3D Systems and basically made it into a healthcare company, which is really exciting. Next, Oliver Shang leads the Health Technology Partnerships and Corporate Development team at Johnson & Johnson. So he's a Silicon Valley guy who has moved into healthcare. And finally, Agnes Binagwaho, did I say that right? Oh, good. All right. Is Rwandan. She was formerly Minister of Health in Rwanda. Some of you have seen her at our program before. She was at our New York conference earlier this year. And she's currently Vice Chancellor of the University of Global Health Equity in Rwanda, which she may talk about a little bit. It's a university that really aims to help grow knowledge about how to transform medical systems and to build more practitioners who can use modern tools across the world, even in the poorest parts of the world, to really make the health changes that are absolutely necessary. And just to reiterate the theme of this discussion, it really is about how technology can advance global health. And at Techonomy, we consider that an absolutely urgent priority. In the description, we refer to the UN Sustainable Development Goals, which, as you'll hear, are very important to us. They are goals for 2030, and one of them, several of them pertain to health, but they're not easy to achieve because they're very ambitious, but we need ambitious goals to change the world. So maybe, ladies first, start with Agnes. Just talk
it's not difficult in this panel. Huh? There is no competition. Okay, lady first.
Why don't we let you just quickly talk a little bit about what you're doing exactly and how to think from your perspective about what the challenge is with global health and what the opportunity is with technology.
So let's remember first that global starts where you have your feet. Every person on Earth is the center of global health. So we have learned by how we implement for success, what are the principles behind that. And there are very few. The first one is leave nobody out. Whatever you do, whatever technology you try to introduce, always think what it will bring to the most vulnerable member of that community. And if you manage it, everybody will cope with it and will use it. So all the others, okay, it takes a couple of years to learn it, but the objective is to create systems that are human-centered, using innovation, and technology are among this. And since yesterday we discussed, is it for the best or is it for the worst? Technology has no soul. The soul is with the human who are using it. And I can give the same question that was asked at the beginning of Gutenberg, when he was doing books. Everybody was saying, oh my God, what is this going to bring? And of course, it has changed the balance of power. Of course, it has increased possibility of education. So this is what we want to do. It's in rural Rwanda, and the principles that we teach are applicable all across the world because the needs of the people are the same, and the way we can leverage all innovation and technology, that's what we teach, and I advise all of you to come and see.
Good. We're going to try to do that, by the way. And it is deliberately located in a rural part of Rwanda because you wanted people to learn in a context that is similar to where the work needs to be done, right?
Yes, because the majority of the world live in rural area. The majority of clinicians are educated in cities. And after that, you ask them, could you go and work where the people are? They don't know how to do that.
Right.
So we start educating where the needs are.
Good idea. Let me just ask you one last basic question. Given that you are interacting in your former position as a minister and in your work now talking to people from around the world with government leaders and health experts from so many countries, how would you characterize the state of awareness and readiness to take advantage of what technology makes possible in the countries around the world, particularly the poor ones that you know so much about?
So first of all, we have to say that we have made it so complicated for people. They believe that it's impossible to achieve, and that's not true. Just think about the phone that has so huge penetration in Africa, and that could be used for everything, for so many things. So technology, we need to simplify it, but we need to simplify the way we talk about it. It's not complicated. You don't need a master to do this. You just have to have some more education that it's simple and you can have on site or during your basic education. Could we start talking about technology in kindergarten, in primary school, secondary school, so it accompanies your life? So it is not complicated. People are aware, but just oppose because they believe it's too much for them. They don't want to look dumb and not capable to use it. And there are many people, unfortunately, who are afraid to lose their power with the old way to do business. So they believe that young, very active people will come and take over their position.
Okay, it's always the job security that comes down in the end. So Oliver, I know one of the things about Johnson & Johnson that we've learned at Techonomy that we're really excited about is the way you really are taking a global view. You're really thinking, how can the innovations that we come up with and the capabilities that we have really apply to improved health in literally every place? So talk a little bit about, you know, the thinking at the company and also how you as a technologist coming into Johnson & Johnson are trying to use tech more, you know, help the company embrace technology as a tool and what's happening there.
Yeah, so technology is exciting because it can be distributed globally at relatively low cost, depending on how you do it. And so the ultimate goal, of course, is improving outcomes. And we think a lot about democratizing access to that care, and technology is the driving force behind that. And so one example I can come up with is, especially when you think about things like income inequality and the lack or divergence of access to care in developing versus developed areas, how can we do better to reduce that and eliminate that? And one program that we came up with was really around improving maternal health and baby health. And so if you think about the efforts that Facebook has made with internet.org to make connectivity available all to every corner of the earth, we think about that in a health specific context. So how can we deliver, in this case, important and critical content and information around pregnancy to pregnant moms? And we've reached, through various programs, over 4 million women, ranging from low-income urban areas in India to parts of Bangladesh and Africa and other geographies. And so this is exciting because sometimes we take for granted in the developed world this access to information. And through these programs, we can push, through mobile messaging, important information that ranges from preventative care to important milestone information about where you might be during your pregnancy, things that might not otherwise be available. And as you were mentioning now, the phones, they don't need to be smartphones. They're accessible everywhere. And so how can we think of simple but yet powerful applications of that to help people?
That must be challenging, though, in all the languages and all the different ways of expression that are needed. How do you localize that?
By prioritizing localization. I mean, I spent a number of years at Google in the early days, and a big thing was when you were ready to launch a product, it needed to be ready in 15 to 20 languages off the bat to be able to reach the 90+% of the world. And in this case, it's developing custom programs in the areas that we want to go into.
Wow. Yeah, I hope you two can talk more. I bet you guys could think of some interesting things to do.
Okay.
And there's a bunch of stuff we want to come back to. I'm going to jump over you since we heard from you a little bit before, but then you can chime in on anything you've heard after we go to Roy. Roy, you as a doctor, and you're thinking, again, very globally, when you think about the situation we're in with what we have available in technology and the health of the world as it stands now, what do you see as our biggest opportunity and our biggest challenge?
Yeah. Well, there are a lot of opportunities and a lot of challenges, I think. And I think I'd like to start out by saying that in the little preamble that was written for this session, which was very well written, I'm assuming you did that. But it does say that the world is the healthiest it's ever been, and I actually take a little issue with that because despite the fact that more...
I didn't say that. It said billions of people are getting healthier. But
okay, all right. That's more accurate. But
I actually think I would argue that anyway.
Yeah.
Go ahead.
Yeah, well, we've already argued over the phone earlier, but we can do it again. So a couple of vectors that are sort of going off in different directions. One obviously is in the medically developed world, rapidly aging population, and in the medically developing world in general, growing population period, both of which are outstripping traditional healthcare delivery. And if you look at that first vector of an aging population, what we now know is that 20% of individuals around the world have 5 or more chronic conditions. And actually the increase in lifespan, which has been significant since 1900, and actually significant since the 1990s, about 6 years added to lifespan globally, that adding to the lifespan has actually created a lot of people that are living with chronic disease, and was already mentioned previously about the epidemic of preventable and chronic disease around the world. 70% of the world's disease now is preventable and chronic.
70% is preventable.
Yeah. So while mortality has improved and lifespan has improved, we're creating a situation where people's quality of life based on health actually is declining slightly globally. And so it's a question of which of those things you think is more important, living longer or living with quality health. I would like to say they both are, and so both things need to be tackled.
But full tech and what we can do with tech into the thought.
Yeah, so there's a lot. So first of all, while I agree that there is a surfeit of technologies we could use in the medically developing world now, we're not using most of them in the medically developed world. We have a number of technologies that we're developing at Philips that have places to land, and some, frankly, that don't have places to land yet because the incentives to use them aren't in place. And most of the world's healthcare spend is in the medically developed world. And we're wasting, about a fourth of what we spend. So about $8 trillion, by my calculations, about $1 trillion in the U.S., wasted about $1 trillion in the rest of the medically developed world. That $2 trillion could buy a lot of technology for the medically developing world. But the conundrum is, or sort of the irony here is that in order for us to free up those funds to transfer them to the medically developing world, we have to use technology more effectively here. And, eliminate redundant care, eliminate unnecessary processes, democratize care so that individuals can do what they can do themselves without the need for a clinician or a big, shiny, hospital facility.
Compliance?
Yeah, all those things that could easily put a huge dent in that expenditure.
The reason I say that, we had a discussion recently with the statistic came up that 40% of Americans don't do what their doctors say. They don't take the drugs they're prescribed. They don't do. So therefore, all the medical intervention in the world isn't going to make any difference if the patient doesn't do what they're told.
Yeah. But that's where the technology sort of loses its luster a little bit, and that's where philosophical shifts have to happen in order to sort of unleash that surfeit of technology. And we talked some about this previously. There's not much pressure on healthcare providers. So I was in a meeting about a year ago with a couple of very senior health system leaders, one of whom ran the medical practice. And I was talking about leveraging technology to lower costs and transfer funds in the medically developed world and all this. I thought it sounded like a great theory. And at the end, he goes, you know, I guess I could write a book on the things I've heard that won't ever work in healthcare. And it's a little deflating. And I said, well, what do you mean? And he said, well, I can't get 50% of my patients to take their medication. At which time I said, do you know why? And there was a silence, just like you heard then. I mean, it was obviously he didn't know why. And so if we had this philosophical shift around, at least in the medically developed world, that healthcare is a human right, fundamental human right, got to be delivered. If we also held the medically developed world to incentives based on outcomes, if you did those two things, you'd create an incentive for different behaviors. And worrying about why 50% don't take their medications. If I'm going to be paid on the basis of how this population looks a year from now, I'm going to find that out.
Okay, but just quickly, if we're talking globally, why are you focusing on the developed world? What do you think would happen then globally if we did that in the richer countries?
Well, again, I mean, most of the money is being spent here, and there's not much left over for the rest. So if you take those Sustainable Development Goals for the UN, so that it's number 3, right? Improve the health and well-being for all individuals at all ages everywhere. And the statistics I've seen is we need to move from about $171 billion of expenditure to about $357 billion of expenditure. We need to go from about $20 being spent to $58 per individual. You know, right now we're spending like 80 or 90 in the medically developed world and 5 everywhere else. And so we need to redistribute some of that. And I think, again, technology is a way for us to actually improve care in the medically developed world, lower the cost at the same time, as long as those philosophical incentives are aligned with the use of those technologies, and then transfer some of those funds to the medically developed world.
Okay, wait, well, okay, quickly, Agnes, go ahead.
I will have another approach. First of all, technology is needed. You cannot bypass it. But behind the technology, there is a human talking to another human in between the technology. What you have lost here is the trust, the social capital. And that's what we teach in the university. Yeah. Because if you come with your pills and your great treatment, there is no trust, there is no compliance. You know that we have double outcome of our HIV treatment than this country, and we don't have $800 per GDP.
Sure.
Here, 70,000.
I know.
And you have half of the outcome for the program with the best drugs. We use generic. We don't have enough infectious disease. So there is something behind the man or the woman that handle this technology for service.
Always, always. You know, but I took care of thousands of patients.
Absolutely.
I was a surgical oncologist. But I can tell you there were a lot of things that I did and the delivery system did that technology could have done. And patients would have been fine with it. And so yeah, I mean, there's always going to be a need for human intervention, but there's a lot of things we do now that technology can actually take off the human plate and actually give us more time to be more human.
Right. I want to ask Vijay, you know, one of the things you had in your slide, one of your slides was that 10% of people in the developing world will have some 3D printed, you know, medical device. That's a pretty stunning statistic, and I wonder how we get from here to there and why that's good. I mean, I think I can imagine why it would be good, but is part of it the affordability of this particular technology and the ability to localize it? Or talk a little bit about how we get there.
Yeah, I think there are 3 things, right? We talked about it. One is digitization. So when why cell phones are very successful, digitization is key. The second thing is, you know, accessibility to the technology. You know, can we make it affordable so that we can make that happen? And the third thing is better outcomes. You know, once you have a patient who is happy that what they got, then this whole penetration is going to go fast. Let me give an example of dentistry, the dental business. So if you think about it, there are 7 billion people, 32 teeth. That's 210 billion custom parts, right?
Okay.
So when you think that way, then say, okay, right now, if you try to buy a denture, it doesn't fit, you try it, and it never happens. But if you digitize your mouth and create a perfect denture, people are going to be very happy. The other important part is right now, most of the processes are subtractive. That means you start with a big block and then cut it to create the denture. In a 3D printing, you only use the material you need to create what you want. Let's take crowns. See, crown right now, when you go to a dentist, they will charge you $1,500. To make that crown, you start with a $25 puck and then create a 2-gram, a crown and sell it for $150 to the dentist, and they will charge you to get to the $1,000 price. If you want to print 2 grams of material, it's only like $1. So the whole cost structure right now and the way that things are done is completely reversed.
But Vijay, is it because we've made some recent advances in what we can do with 3D printing that you can even talk that way?
Yeah, well, I think it starts with materials. The whole thing is biocompatible material that you will be able to customize, mass customization, at an affordable price is going to change the world. And that's the only reason the focus that we have is on materials. We start with the material, start with the technology with which. The other important part is this technology, mass customization. That means I can go to Africa, and in the dental labs, we could put the, this particular device for way lower price than building a big factory of creating the
and print it right there, either in the dentist's office or in the clinic or whatever. Yeah.
So I think this whole digitization, access to the technology, then the cost structure is what will take. Think about hearing aids, right? Everybody wants the shell, which is kind of fits. 95% of hearing aids are done with 3D printing. And the reason for that is you could do mass customization at an affordable price, which you could globalize.
All right, that's great. So Oliver, I know one of the things that's sort of not entirely intuitive for non-medically educated people that you guys are putting a high priority on is reducing mistakes, right? Talk about that and how you're thinking of that and what the opportunity is to scale that.
Yeah, so if you've ever read or are familiar with a book called The Checklist Manifesto, it's based on a very simple but powerful premise that by following checklists for certain types of procedures, you can reduce mistakes. So we all do this in everyday life, to-do lists, grocery shopping, whatever. But imagine that applied to a higher stakes environment like the operating room. And so when we think about where technology can really play a big impact, I think this notion of a more connected operating room is really exciting. And there are many ways in which you can think about this idea of better efficiency through things like reduced mistakes. So I think on one end, there is software out there, and in fact, we recently announced an acquisition of a software startup company called the Surgical Process Institute, which creates this hardware-software solution in the OR that takes most of the surgeries, which can be standardized, not the types that you demonstrated, of course, but many surgeries where you can create a standard checklist of steps to make. And by following that, you can help surgeons focus more on value-added areas like where they can intervene or when things might go wrong. You can reduce the possibility of forgetting a critical step. You can importantly measure this and provide education and training back to the hospitals themselves. And you can even eliminate process waste by making it easier for people from the surgery teams to swap in and out because they know seamlessly what they need to do. And so this is really powerful stuff. And it turns out it also has the benefit of reducing a lot of costs for hospital systems. So reduce the variation in these steps and you reduce the variation in the outcomes. That's better outcomes for the patient, of course. You eliminate all this waste from the process. That's great for the systems themselves too. And so it's a very powerful but simple application of technology.
Yeah, I agree with you. We showed a very complex, right? But you can apply the same principles in terms of digitization, simulation, and figuring out how to train the surgeons. And you could take a lot of waste out, and you can get a much better outcome. This is just starting. Always technology develops at a high end, and then comes down. And then I think that could be a very powerful way to really focus on the outcomes.
Yeah, and it doesn't have to be this super high-tech implementation,
right?
And it doesn't have to be really expensive. So you can have your high-end OR with your monitors everywhere, with the speakers, and everything's controlled by the foot pedals. Here's your next step. But you can also have them implemented at the local level through just having a
but the whole virtual reality is going to change the way you train the surgeons and the way you get the right kind of an outcomes, because that's what I believe that's going to happen.
I don't know what Paul Bunyan's doing out there, but and it distracted me. But did you mention your partnership with Alphabet? Because that's an interesting aspect of what you're talking about.
Yeah, so that's another part of what I would call digital surgery. So we have a joint venture with Alphabet's Verily division, where we're co-creating a robotic surgical tool. And so again, the idea behind this is to make more precise movements, to utilize the technology where it really makes sense. And you can call that reducing errors if you want, but just like we're moving to a world of autonomous vehicles, which in theory will reduce accidents and that sort of thing, having robotic-assisted surgical tools can help with that too.
We work with a few people there.
I hope someone's actively investigating why we're hearing this bumping. But anyway, yes.
I don't think it's an earthquake.
What?
I don't think it's an earthquake.
It's not an earthquake.
It's already the ghost of artificial intelligence.
Yeah.
That was good, Agnes. So it is distracting, let's admit it. I mean, and it's getting more frequent. Simone's not here. I assume that means she's trying to deal with it. So, Roy, I don't know, any thoughts that you've been prompted by with other stuff you've heard here? And I do want to go to the audience, but,
Yeah, sure. So we also believe at Philips that we sort of back up into the types of tools that can be used by clinicians to make them more efficient and save cost. We have platforms for radiology, pathology, oncology, genomics, all of which are intuitive and are using AI to learn how clinicians work and make them 30 to 60% more efficient, more throughput, and so forth to save costs. Those are some very real-world applications of AI. There's a lot of hype around AI, but those are some places where we're actually using it. Not really directly touching patients, but just making clinicians more efficient and lowering the cost. I do think it's interesting, though, to talk some of the things we're talking about here, because the traditional medical industrial complex is based on interventions and acute care. A lot of things we're talking about, have their origins there. The question is, those advances, of course, are easy for healthcare providers to latch onto because those are already revenue-producing areas of healthcare delivery, and you can lower the cost and make even more revenue. But where I'm really interested in seeing us, pay more attention is the 65-year-old obese Hispanic diabetic living in a rural United States or in Central America that doesn't necessarily have access to technology, doesn't need to have a major surgical procedure or have a robot, just needs to better manage diabetes. As it turns out, that's driving most of the healthcare costs around the world. And when I talk about realigning the incentives and having philosophical shifts to leverage technology to really lower the cost, not just to make us more efficient and better outcomes, which we all want. I mean, I would have loved to have had some of those 3D printed models when I was operating. It would have been great. But there's a huge vista of more opportunity outside of the context of traditional acute high revenue care that the incentives just aren't aligned to use technology. And that's where I'm hoping we focus more of our attention on over the next decade.
Agnes mentioned mobile phone as it's really a fundamental social transformation that everyone has this, increasingly everyone, 3 billion people or something close to it, and growing toward everyone have these little things with them at all times. That really is a key tool in this process, is it not? I mean, and maybe Agnes wants to chime in on that further.
I just want to say that it's not only for clinicians. Like in Rwanda, 45,000 community health workers has a simple phone at $5 a phone. And with that, they alert in case of outbreaks, in case of somebody need an ambulance, and all this information are centralized, analyzed, and at the end, for the first time, we know what happened at community level. But also, 13 software help the Ministry of Health to manage the health sector. Yep. That means it makes it more affordable for the people in remote area, more equitable, and also better management. It's part of affordability.
It's also interesting to note regarding Rwanda that one of the things that makes Rwanda so different, and correct me if I'm not explaining this right, is that the way the government has worked is it has really driven a lot of resources to the local level. So the village, the region has a lot more resource and decision-making capability. So that I think, and that is not the way most other countries in that part of the world have structured themselves. And that gives you tools that other countries lack. Would you agree?
That should be the way to go, because where the people are living, in their home. And
right.
They don't live in the ministry. So don't put the resource in the ministry, put there.
I mean, this is not just at healthcare. I think the whole point, Kagame has directed a lot of resources to the village level, right?
Absolutely, because that's the place where people live. And also health is an integrated thing. You cannot manage health without having a multi-sectorial approach, centered to people. But it's so logic that this needs a panel per se.
So one more point I want to make is education. I just think that educating nurses and doctors with this new digital technology is very important, because I really think that our current curriculum is not really adapted, and you could actually train doctors and nurses to do gallbladder surgery.
Absolutely.
And I think somehow we are still using the old ways, and I think we need to transform that. Because
VR and AR are part of what you're talking about.
That's what I'm just saying. Because more you do that, more, the help will be there, because as you look at the ratio of doctors and nurses to the patients.
But not only in developing countries. Here, there are a lot of regions without hospital because they have closed. So you need a community approach, but you don't need a specialized approach at community. You need access to tools that they can give and link the people to health.
Okay, let's get the lights up, and who has a question or a comment? Right there. Can we get the mics? Thank you. Oh, boy, you are so good.
Wow, good to see everybody.
He's right there. All right, thank you.
Hi, Drew Van Eekirk. I'm a veterinarian from Canada. I'm curious as to where we are with listening technology, artificial intelligence, and the ability to medically chart. I don't know about the human world, but in the veterinary world, it is incredibly inefficient and onerous to chart your visits and your care and your plans and everything else. It requires a lot of manual input, and it seems to me the technological opportunity is to have systems that might be able to record as you go and be smart enough to use key phrases to construct a medical record for us and take the low-hanging fruit of efficiency in the doctor world. What do you think?
Any thoughts from anyone?
Dr. Smith, start, I guess.
Yeah, so I would fully agree. So there was a study done a couple of years ago that suggested that in North America, including in Canada, the average primary care visit is 13 minutes long. And then since that time, what we've ferreted out is that 39% of that 13 minutes is documenting. And usually not documenting exclusive of any interaction with the patient. So now you got it down to 8 minutes, right? Wow. And the average North American sees a physician 4 times a year. So that's 32 minutes a year of face-to-face healthcare. So we're actively working, and a number of other companies are as well, on using natural language processing and auditory processing to improve documentation. It's not far away. And all you have to do is come to my house and have breakfast with me and sit with my 12-year-old and my 7-year-old and Alexa and myself, and I can demonstrate to you how it's not far away. So it's a great question. The key here is both for clinicians doing things, documenting things, and for patients being monitored and evaluated and followed exclusive of their interaction with clinicians, the more passive, the better. If you ask people to do things outside the context of their normal lives, put a watch on, type something into it, type on a screen, it always quenches. And so we talk a lot about passive monitoring of patients, but we need to be a little bit better with clinicians as well, making their jobs easier so they can be more humane.
Yeah. Never forgot that. And also, when they took 30 minutes to record that, nobody can read it because it's a doctor or nurse's.
or it's embedded in an electronic health record chart. When I was on the Texas Medical Board for a number of years doing disciplinary work, and we would have to get the charts on physicians that would make mistakes, and we would get a printout from the EHR that was 120 pages long, and we could never find the medical record.
Yeah, because
So
it
it's not
was
just the
designed
written
for
thing.
payment.
Yes, yeah, exactly.
The EHR is designed for payment, not clinical progress. Okay, back there, please.
Thanks. I'm Catherine Cheney, and I work with DevEx. We're a media outlet focused on the global development community. And of all the stakeholders that have come up, we've talked about governments and technology companies. I wonder if you can point to the role of donors and NGOs in this space and any advice for them or hopes, what you hope to see for them in navigating this.
Interesting question. Good question. Anybody have any thoughts?
So donors and NGOs, where they want to work, should sit with government and civil society and ask what suits you in your level of development. And go directly to the best. Don't believe that because you are poor, we are going to start by paperwork. No, let's go to technique and make it fly. So there is space for everybody.
Anybody else have any thoughts on NGOs? Because certainly they are a critical part. If we're going to make global health go fast.
And never forget that government are not implementers. They are regulators who implement civil society, workers, etc. So there is space for everybody.
Okay?
So a lot of what you guys
Identify yourself, sorry.
Sorry, Sam Abadir, Aspire Ventures. We're a health and AI VC fund partnered with Penn Medicine, Capital Blue Cross. So these views are my own, not theirs. A lot of what you guys are talking about is precision medicine. I'm wondering about the barriers to entry in the market when you're printing a part for each person or developing therapies for each person. What do you think the prospects are of getting through those regulatory issues, et cetera, and getting into market?
Yeah, I think I can start. I think that's a very important step here to take. We have invested a lot in really building the right kind of a infrastructure so that we can track at every step. There is because the requirement from FDA point of view. The other important part here is we need to do it globally because you just can't do it in the United States because this is a global thing. And, you need to understand all the laws in various countries and make sure that not only the infrastructure and the tracking is there, but that's fundamental because, when you are asking to put a crown inside the mouth, you need to have all the approvals. And so my view is you need to really make sure that you consider that there is going to be a time where you need to get all these approvals done, and that could be a barrier, but also a competitive advantage.
Oliver, how does J&J think about the regulatory challenges?
Yeah, I mean, for better or for worse, that's a reality, and so I think the technology by itself is not going to be sufficient. I think you have to really marry that with not only the scientific expertise, but that regulatory expertise. So in many ways, it's necessary. I think one step that we've taken is working with the FDA's new program to pre-certify digital health software initiatives. And so really exciting, obviously very early, but participating with the likes of the Googles and Apples and Fitbits of the world. And so there are steps out there, and it's encouraging that they're trying to think innovatively like that to streamline those things, and we're looking to participate in that.
Oliver, do you agree with what Roy was saying about the passive things making more sense if we can find where they are effective?
Yeah, I mean, behavior change is hard across the board. And so it's a tough nut to crack. And how do you design technology applications to help change that? I think on the consumer side, there are a number of things that you can think about utilizing apps and those types of things. And we created a digital platform recently that we launched called the Health Partner, where we're working closely with the systems themselves and connecting that to consumers to help them understand not just the physical elements in preparation of surgery, but the emotional and mental elements as well. So the entire sort of mind, body, spirit approach. And it was really a great breakfast this morning with Dean, thinking about it's not just motivation through fear, which doesn't really work. It's the motivation of joy, and how can we implement technology to help people understand that in ways that aren't creating these artificial behavior changes.
Social capital again. And also, don't believe that behavior change is so difficult. Remember how the world was 20 years ago. We have totally changed.
Right.
So behavior change is less difficult than we believe.
Wonderful. Well, we've run out of time, but thank you, all four of you. Really good conversation. This is a conversation that will continue at Techonomy, and I hope plenty of places. So thank you all for participating.